Good afternoon, everyone. My name is Christie Edwards. Thank you so much for joining us. I am the Director of International Humanitarian Law here at the American Red Cross, and it is my pleasure to welcome everyone here today for a conversation about the risks and protections for healthcare during conflict. And I'm very, very excited to have some really, really wonderful experts in their field join us today for this conversation. And if any of you happened to watch the interview that we had on Thursday afternoon with Len Rubenstein, we covered some of the overall history and foundations of this topic, some of the legal frameworks, and so I hope that you'll all take a look at that online. It's on our blog if any of you want to take a look. It's humanityandwarblog.com. And for those of you who are watching us online, please do tweet in your questions. Our hashtag is #HumanityandWar, and you can tweet them to our Twitter handle @HumanityandWar. I'm going to give a brief overview or introduction of our speakers today. I won't read their full bios. For those of you who are in the room, you do have them on your tables, and for those of you watching online, the links to their bios are also listed on our blog. But for those of you who are joining us today, I'll just give a few brief highlights, and their experience is very long and quite incredible, so I won't read everything, but just to give you a sense of really the extreme expertise that they bring to this topic. I'm going to start with Susannah Sirkin, who is the Director for International Policy and Partnerships at Physicians for Human Rights. And she's worked for Physicians for Human Rights for almost 3 decades in a variety of roles, and has really, really incredible experience working in Darfur, Yugoslavia, Rwanda, Afghanistan, Burma, El Salvador, Haiti, India, Iraq, Israel, Kosovo, Kuwait, Palestine, Sierra Leone, Somalia, Turkey, and the United States, among many others. We are so excited for her to be joining us today. She's currently working on a new effort by PHR to train doctors, lawyers, law enforcement, and judges to respond to sexual violence in conflict zones, particularly working in DRC and Kenya. And so we'll be talking a little bit more about that later today. And she also represents PHR on the Safeguarding Health in Conflict Coalition, which is headed up by Len Rubenstein, who we spoke with last week. Well, actually, we're not going to go to order. It's going to be more of a conversation today. But we also have Michelle Mays joining us today. She is the Deputy Head of Mission from Doctors Without Borders. And she joined the organization in 2008 working as a nurse, project coordinator, and Deputy Head of Mission. And she's worked primarily in contexts with conflict, natural disasters, and epidemics in places such as India, Haiti, the DRC, South Sudan, and Central African Republic. And so we're really, really thrilled that she could join us today as well. And for those of you who have joined us for some of our events before, you'll remember Neena Jain, who is an absolutely amazing emergency physician with over 20 years of experience working for large and small organizations in a variety of conflict and disaster contexts. She's worked throughout Africa, Asia, and the Caribbean for organizations such as Doctors Without Borders, the International Medical Corps, Australian Aid International, Save the Children, and many others. So thank you so much, ladies. We're so thrilled that you could all join us today. And as I mentioned, we're going to have more of a conversation style today instead of what I feel is a little bit more of a boring panel. I prefer to have them answer some of the questions that I know are on all of our minds, and then open it up at the end for questions from many of you here in the audience today. So we're going to start with Susannah to give an overview of the healthcare and danger issues. And Susannah, if you wouldn't mind describing the difference between attacks during conflict and other conflict situations.
Well, it's an interesting question because even though it's an interesting question because even though we have different sets of norms and laws that protect the delivery of health care and the role of health professionals in conflict and non-conflict situations. In other words, humanitarian law and the Geneva Conventions during wartime and other armed conflicts, and human rights law that actually spans all of these situations. We actually see a continuum. It's very difficult to say, well, this violation occurred in a war and that one didn't, in fact. And that's because increasingly we're seeing civil unrest and situations of intercommunal violence that wouldn't really be called armed conflict under IHL, under humanitarian law, but where the same kinds of things are happening, meaning attacks on health professionals, invasion of hospitals, barricading of health facilities, interruption and disruption of medical transport, looting of medical supplies, and actually direct attacks, including torture, arrest, execution, and disappearance of health professionals themselves. And these actually span everything from peacetime, sometimes, unfortunately, to civil disturbances and civil society demonstrations and civil unrest, all the way through to full-out wars. We do see in so-called peacetime the interruption of health care that occurs really as a criminal activity, where people are attacking health transport or medical supplies for pure theft. And we also see attacks on health professionals and institutions when health professionals maybe are, for whatever reason, mistrusted or misunderstood by the population, such as we've seen in attacks on polio vaccinators, or even in West Africa in the early phases of the recent Ebola outbreak, where health professionals who were coming into villages and were seen as in some way dangerous were attacked.
Great. And I know last week Glenn mentioned that obviously there are legal protections under IHL and international humanitarian law, but then there are also frameworks under international human rights law. And because conflicts do operate in many cases on a spectrum and going back and forth, et cetera, it can be quite complicated. Neena, I wanted to follow up with a question to you about the immediate effect of disruption of the healthcare, of the infrastructure in the healthcare system, supply chains, et cetera, but also the long-term indirect effects that conflict have on healthcare systems.
Thank you. Yeah, so what we normally define as direct effects technically is that direct deaths or direct mortality is due to battle-related or immediate combat-related wounds. However, the indirect effects are literally you take the deaths that follow conflict and subtract the deaths that would have otherwise normally occurred. And so that's often defined as indirect mortality or excess mortality. And there was a study not too long ago in the Democratic Republic of the Congo by the International Rescue Committee that found that actually direct mortality was only responsible for 0.4% of deaths. The remainder was due to what we would normally say is excess mortality or indirect. So you can really see, and Dr. Rubenstein in your interview last week did a really nice job of explaining, for example, in Syria, where the disruption of healthcare is an attack on healthcare, and the long-term effects in terms of chronic and infectious disease is huge. And so if we start to actually look at this context as a generational impact, then I think we can all stand to improve our programming and actually stand to improve our outcomes. In addition, it's not just the qualitative aspects and quantitative aspects of healthcare, it's all of the other infrastructure that's related to health and well-being. So water, power, power supply, in terms of electricity, education, maternal care, everything is affected, and so that also disrupts the lack of access.
As a follow-up question, can you, given your experience in the humanitarian sector for your career, what do you think that the humanitarian assistance providers and the funding systems that account for the long-term structural violence and the substantial effects of conflict, how can they better address these issues?
That's a great question. So I think that it's all incumbent on each of us as humanitarian practitioners, as an everyday citizen, as people involved in policy through on-the-ground program decision-making and in government structures alike, is to really recognize this as the generational impact, as Susannah laid out the foundation that this is happening, it's worsening as we speak, it's current as well as previous crises. And so to build our programs as well as our funding mechanisms to support the longer-term infrastructure redevelopment is absolutely critical, and for each of us in our work to understand that and to incorporate that.
Great. Michelle, I want to turn to you because you've spent so much of your career working in the ground, in the field on many of these conflicts. In your opinion, how how should we best, or how can we best protect local staff healthcare workers? Because I know that there are, I mean, many of them face absolute, just the face of arrest, imprisonment, torture, and for various reasons. Can you maybe give us a little background on that issue?
It's such a hard topic. I think it's something that we really debate a lot in the field and with our teams, and when I'm leading a team, it is a constant source of debate, both with our international staff and with our local staff. Because of course, our international staff, they come in and we have an obligation as an organization to send them home at the end. We don't have that same obligation to our local staff. They're from there, we hire them there. And that does put a really, really difficult ethical dilemma to us as employers, but also working in the healthcare field, that puts kind of an extra level of complication and it's just difficulty. So I think it really depends. One way to distinguish is that things will happen to members of our staff just because they are part of the communities where there is a conflict. So because they come from X ethnic group, or just because they happen to live in this village, that something may happen to them, and that can be different from them being targeted as a healthcare worker. So it's important to be able to see that distinction. At the same time, we also don't want to make healthcare workers exceptional in the sense that the death or the beating of a healthcare worker is somehow, why should that be worse than the death or the beating of any member of the community, right? And especially as healthcare professionals, that's a difficult ethical thing for us, because a person is a person, a patient is a patient. It's not about what job or profession you have. So it's not an easy thing to look at or to generalize. And I think, a good example is when I was working in Central African Republic, one of our staff was arrested and beaten by the local military group. And the next day they allowed him to come to our hospital for medical care. Well, I know that that's because we have a relationship with the military group, because no one else that they arrested and beaten were allowed to come for medical care to our hospital. But then they wanted, once the person had been treated, they wanted him to come back because he was under suspicion. They were accused him of being a spy for the other side. So then this person now has several identities. They're a member of the community, they're a staff member of ours, and they're a patient. And that kind of ethical dilemma of dealing with and how do you negotiate with those different identities is really, really complex, and it's something that I think has to be dealt with. Every situation is different, so it's hard to give a general answer, but those are kind of some of the issues that we have to deal with on ground level.
Are there any protocols currently in place or best practices that you've seen to address some of these complications?
Again, it's hard to make generalizations. I mean, best practice is that you don't make generalizations. I think that's probably the best practice, that you really have to look at each context very specifically. And I think, we take our responsibility as employers and as well as healthcare workers very seriously, and that if we walk in line with the ethics in that way, that usually can give us good guidelines of how to proceed. But it's difficult. I think though it's really important to be upfront and transparent with your staff about the limitations that you have as an employer and as an international organization, because there are benefits to that, but there are also drawbacks, because at the end of the day, we're not from there. Like, we leave and they don't. So it's really important to be upfront so that you don't wait until something like that happens, that the staff already know what to expect. So that's one, I think, big thing about being transparent. And as well, doing what you do anywhere. You try to build really good relationships with the local community, and so they understand where we're coming from, and that's about the staff, but it's also about, being treated and being understood by the community and by the local militias and authorities and things like this.
Susannah, maybe I'll ask you a follow-up question to that. What role do local providers and local agencies play in addressing these kind of vulnerabilities? And how can they be more included in protected settings of conflict or post-conflict?
Yeah, well, it's an interesting segue because as we just heard, in international crises, international organizations such as Doctors Without Borders and many others come in, and as we know, they eventually, the workers can leave or will leave. And increasingly, I think there is a growing understanding that what's left behind needs to be supported and sustained. It's not always possible for the health providers on the ground in terms of their mandates and their organizations and the protection of their roles in a particular country to do everything that's needed. But what is really needed are systems of protection locally. And the first obligation is to those who under law are required to protect health and the delivery of healthcare and medical ethics in country. And that would be the local ministries of health, the police, the security forces, the independent or government-operated health associations, so the nurses associations, the medical associations. They should all be doing what they're tasked to do under law, under their own laws and under international law, which is to protect the independence and availability of health care, A. When that fails, then that's where we all come in. And I believe the Safeguarding Health and Conflict Coalition and groups like Physicians for Human Rights, we see one of our roles to increasingly create an environment in which the international community mobilizes when people on the front line, such as our colleagues right now, who are dying every day in Syria by direct attacks by their government, are supported. And that means gathering the data, putting it out to the public, going to policymakers, bringing it to the United Nations, bringing it to the World Health Organizations, speaking out, and basically creating a much stronger movement to defend these colleagues.
I have a quick follow-up question, but I've also been reminded to remind everyone here in the room and online that if you have questions for any of the panelists, please tweet them at Humanity in War using the hashtag Humanity in War. So on that point, last week Glenn mentioned that there's been a UN resolution on the protections for healthcare workers, that there's been a lot of advocacy work done in the international community, both with the Safeguarding Healthcare Coalition and then also with organizations like the ICRC, which have put together a long list of best practices and suggestions for what can be done. What else do you think could be used to strengthen this area of protection?
Yeah, well, as Len mentioned, we're still very weak on the data, and we need the World Health Organization to move forward much more robustly in requiring ministries of health and independent organizations in the UN to collect this data. Second, and he mentioned this, and Physicians for Human Rights is very supportive of this as well, we need to prosecute these violations. And we have not seen prosecutions that are directly focused on attacks, direct, intentional, targeted attacks on health professionals or health facilities in war, and these are war crimes. And so we need to gather evidence that can actually be used for domestic or regional or international prosecutions. That's absolutely critical, because as long as these violations go on unaddressed, where no one is held accountable and the perpetrators are not held to account under a court of law, they will continue. And they'll get worse, and that's what we're seeing right now. There's no accountability. So that's the second thing. Third, I think that there's much more that can be done with this new UN resolution. The United Nations General Assembly passed its first ever resolution on protecting health workers on December 14th, 2014, so it's brand new, and it strengthens and reinforces the norms against attacks on health services and health care workers in both conflict and non-conflict situations. So it remains now for us to hold all the member states of the UN who passed this resolution unanimously to actually act now to implement this resolution.
That's fantastic. Susan, I'm sorry, Michelle, if I could turn back to you. When the effect of these crises burden segments and subsegments of populations disparately, what are some good examples that you've seen that have been implemented for addressing these needs? And I guess what I'm trying to get at is for very discrete members of the population that might not have access otherwise, people with disabilities, pregnant women, etc., how do you make sure that they are protected during these kinds of conflicts?
Yeah, easier said than done. I think that, the obvious answer is nothing new. It's, when we look at anything from a public health perspective, we really try to address everything. And And when we talk about a doctor-patient relationship, we talk about treating the whole patient. So that means the woman when she's pregnant, when she has 3 children, treating her 3 children, treating the husband, treating the aunt, looking at the whole patient, the whole family, the whole community. So it's about, it starts with best practice in medical care, which means that we really have to think through the full life cycle of a person, of a family, of a community. And the best way to do that is to provide comprehensive health care, which is obviously easier said than done in a lot of these places. But I've seen a couple of different innovative things. Sometimes they happen by design and sometimes they happen by accident. An example of it happening by accident is, again, in Central African Republic, my favorite country of examples today. We had, before the conflict started, the most recent conflict started, we had started training lay healthcare workers in diagnosing and treating malaria. And we never really got very far with it because then the conflict broke out and it was very difficult to continue with that program. But we already had some people who were placed in different villages, and there was some fighting in one of the villages and people ran into the bush. And a few days later we went looking for the population and for these healthcare workers or these lay staff who had been trained, and found them. And the first thing the guy said to me was like, look, I have all my malaria treatment and all the tests, and I'm testing and treating people in the bush. And I was like, okay, this is great. Like, we never really planned for this, but now people are getting medical treatment in the bush. And it's things like that. And it's really the resilience of a lot of the communities that we work in. I wouldn't have necessarily had that idea, but they know how to do this. Like, we just gave them the tools and the training, and they were able to find a way to treat their population. So it's also, I know we use the word empower a lot, but it is really about empowering and giving the communities the tools, because I didn't grow up living in the Congo or in a jungle fleeing from conflict. So I'm not going to think through things in the same ways that people who come from these places do. And so, if you give them these tools, that they're really able to find ways. And they, again, we also say, like, listen to the population and what they have to say. They will also tell you, yeah, but actually what we really need is this. And, oh, right, of course, like healthcare for pregnant women, that would make sense. So, there's this example we were talking about before in Syria, where a woman had to cross back into Syria to get maternal healthcare, which is ridiculous. So, like, why are we not thinking about this as the international health community? I mean, that's on us. Like, that does not make us look good. So, therefore, we need to make sure that we're really looking at everything like we would in any context. Like, you just have to look at the whole person, the whole community.
That's absolutely crucial in order. I think we talk a lot in the humanitarian sphere about resilience and definitely talking to local populations about their needs and about ways in which they already work. And then just giving them the tools they need is the best way to make resilient communities. Neena, you mentioned a little while ago some polio outbreaks, and there have been measles outbreaks in the Nuba Mountains. Can you talk a little bit about why these are happening, especially for diseases like polio and measles that have been almost eradicated completely until this point?
Yeah, so with both polio and measles, just at your baseline, you need, for both of them, you need a very high percentage of the population covered in order for the vaccination to not only interrupt transmission, but also to maintain that interruption. And so when you think about a conflict or a crisis-affected setting, you think about, well, that's already disrupted. So in polio currently, and as you and Dr. Rubinstein talked about last week, Pakistan is currently a very volatile position for eradicating polio. And then in Africa, the 2 countries that remain very highly on the list are Somalia and Nigeria. And so not only currently, but also historically, the places in which polio has come back has been in conflict-affected or currently in conflict countries. For measles, we talked about the current measles outbreak in the Nuba Mountains in South Sudan. And estimates are about 150,000 children under 5 are at risk. And already, I think my statistic is quite old already to this point in August, but in July there was over 2,000 cases of measles that were found. And just to, we sometimes get lost in the numbers, but I will tell you that from a physician's perspective, 1 child dying from a vaccine-preventable condition is absolutely heartbreaking. And the children that I saw with measles in northern Nigeria, actually when I was with MSF, MSF were some of the sickest kids I'd ever seen in my life. And so to even just have one child experience that condition that could have been prevented is very significant. And the other point is that when we talk about access, we don't mean just geographic access to the populations. We mean all different kinds of access. So it's geographic access to the populations, their access to us, but it's also financial. I mean, there's many circumstances, including the case of the women receiving obstetric care in Syria, where they had to cross back into Syria because they couldn't afford a C-section. So financial access is not always guaranteed given the humanitarian intervention. So to think through the various different impacts and definitions of access.
Thank you. Michelle, can you talk a little bit, the decision when these organizations like MSF are under fire and under attack, hospitals are being attacked, healthcare workers are being attacked, the decision to pull out of a country is not something that is taken lightly. And there's been a lot of conversations about the MSF withdrawal from Somalia. And I know that this is not your job, but from an organizational perspective, can you talk a little bit about what sort of decision-making factors went into that and how the thinking is about when or if it is safe to go back in?
Yeah, that was one of the hardest decisions that we've ever had to make as an organization. We had been there, I think, 22 years or something like this. And it just got to the point where we could no longer negotiate safe space for our teams to work. And it's not just about the physical safety of our teams, but also that we could work independently, meaning as doctors and nurses, we could provide the medical care to the patients that they need, not that we were being told to or directed to. And that was really, really challenging because, for anyone in the medical field knows, you just to leave patients is impossible. How can you do that? It's really, really, really challenging. But essentially it was that the same people that we were negotiating safe space with were the same people who were either actively or passively supporting direct attacks on us. So either because they weren't holding accountable people who had, we had 2 staff members killed, we had 2 people kidnapped, 16 people I think in our 22 history staff members have been killed. So it comes to a point where you have to say, we just can't, and that's essentially what happened. But as we would love to renegotiate, to go back in, and that happened in Afghanistan. Afghanistan we left in 2004, and we were able to go back in 2009 because space opened up over a lot of time and a lot of discussion. But we have to be able to provide the medical care that we think is necessary in an ethical way. And another really concrete example is Libya. We were providing healthcare to people who were in detention centers, and essentially what ended up happening is that these prisoners were being tortured and taken back to the detention center. MSF was treating them so that they could get back up to a level that they could go back and be tortured again. So, we can't, no. Okay. There's not really a discussion there, and we had to leave. So, it can be for many reasons, but it essentially comes down to us being able to provide the medical treatment that is needed, and us to be able to decide that as medical care workers, and not to be told this is what you do or this is what you're allowed to do or not allowed to do. And that's really the essence of our neutrality and impartiality.
Neena, I know you've worked in some places where this has been on the table or been discussed. Do you have any thoughts you want to add?
Yeah, I just think that having worked with both small and large NGOs in our current organization, our entire focus is to work with community-based organizations. And I think this decision around pulling out has to start even before we enter into any situation. And we give a lot of talk around planning our exit strategies, but particularly in any area of crisis or conflict, it has to happen before we enter, and to plan your protocols and what ifs prior to that. And it's not always something that is done. It might have happened later. But it's also, when we talk about transferring risk, and that risk is not equally felt across our community-based partners, is to help them also plan their risk management and their strategies while we are there, and planning for the worst but hoping for the best.
Again, just a quick reminder to those of you who are watching online, you can tweet questions at Humanity and War using the hashtag Humanity and War. Susannah, I had another policy question for you. I know that there's been, we've talked a little bit about the ethics, and that's something that we talked about with Len last week too, and this is obviously a really important issue for him. And there have been instances, as Michelle actually just mentioned, treating patients to the point where then they can be tortured again because they're at a stability level. There's been those who have conscientiously objected to being forced to force-feed a patient who is in detention. So what kinds of issues come up in the policy world, and how are these being addressed?
Well, definitely this issue of torture and occurs in custodial settings, and in fact, Physicians for Human Rights worked in Turkey in the mid-90s when Turkish prison doctors were required to give a medical exam to prisoners before they left the prison, and repeatedly they were seeing brutally tortured prisoners, and they were falsifying the information and saying that they didn't see anything wrong with the prisoner before the prisoner was released. And in fact, when we started to research this, we did a whole study and report on it. We found out that the doctors didn't like doing this. They knew it was against their medical ethics, but they knew that they could have been fired or arrested or themselves tortured for reporting torture. So this puts local health professionals, this issue in a very extreme bind. And so one of the things that we do, and MSTPH does, is try to educate not only health professionals themselves, but all of their officials about these norms. But unfortunately, in the United States, in the context of detention, security detentions post 9/11, and especially in Guantanamo, and for sure in the black sites, health professionals have unfortunately been asked to, and sometimes have compromised their core medical ethics by participating not only in force feeding, which is understood by all major medical associations to be a violation of medical ethics, but also in torture. And this has come out now more and more, and we've seen some pretty amazing things happen just in this past few months with the American Psychological Association getting rid of most of its top echelon when it was exposed that American psychologists and the Psychological Association itself was compromised and involved actually in corrupt behavior, in participating in interrogations that amounted to torture, but also just this past week, or last week, in Israel, where a Palestinian prisoner who was on a hunger strike almost died, and Israeli doctors and the Israel Medical Association across the board refused to violate their ethics and force feed this prisoner, even though the Israeli parliament had passed a law requiring doctors to force feed. And there was like an absolute bulwark against this violation of ethics. And what happened in the end was the prisoner went into a detainee without charge or trial, and that's what he was protesting. He went into a coma, he was brought into the hospital, he received some medical care, and then he was now conditionally released. And so the situation has been somewhat resolved, but it's really, I think, remarkable that there was this absolute understanding across the board of these medical ethics. I actually wish that in the United States we had something similar, but we did have very prominently a Navy nurse who refused to force feed on Guantanamo. He was sent home. His lawyers defended him, and the American Nurses Association gave him a Human Rights Award just a few months ago here in Washington for, again, standing up to medical ethics, even when his sort of military command was asking him to violate them.
Great, thank you. I've received a follow-up question actually for Michelle and Neena. What factors are considered when thinking about re-entering a conflict zone after having withdrawn because of a lack of safe space?
I'm trying to think about, okay, a good example of this would be in South Sudan last year in Lear, which is in Unity State, and this is one of the hotbeds of the current conflict in South Sudan. And basically the whole whole town was burned down, including our hospital. And of course, you know, they knew what they were doing. A hospital is a hospital. Everyone knows what a hospital is. But they also burned down the whole town. So, you know, we can say, like, oh my gosh, you burned down the hospital. But yes, they also burned down the rest of the town. And we had to do a lot. There were a lot of negotiations and discussions that went into re-entering and making sure that our teams could be safe going back. And you know, the challenge of places like this is that when it's one thing to come back after the conflict or after the front line has moved somewhere else, but it's a lot harder to go in when the conflict is still actively there. So, and we had to go back and have really serious discussions about safe space and humanitarian space, and this is an ongoing battle. But Afghanistan is another example of where we've been able to successfully do it, and one of the big parts of that negotiation was talking about the no weapons policy, no weapons inside the hospital, to ensure the safety of our patients and staff, and to make sure that the conflict doesn't also enter into the patient wards. So it's about being able to say, okay, this is our red line, and as MSF, we have a lot of experience working in conflict areas, so our red line is pretty clear usually, and we have to make sure that we can go back and have those assurances. But even sometimes we have those assurances, they're violated, and that we've seen many times as well. So it's also for us as an organization to really look at the risks and do a really, really complete risk analysis, and this is something we have to do repeatedly over and over, is revise the risk analysis, and then decide if those risks are acceptable to us. So there's not one answer, but those are some of the things that we consider.
Thank you. There's a follow-up question actually about best practices and protections for healthcare workers during conflict. The no weapons policy is fantastic. Have any of you actually seen other policies or practices that have actually led to more protections for healthcare workers?
I think identification of staff is really useful. In some of our projects, everyone has to wear some kind of identification that identifies them as being part of one organization or another. That's very useful in that it's very visible. But then, you know, I know situations where someone's on a motorbike and it's raining and they're wearing a raincoat and they don't see that they're wearing an MSF t-shirt and can be stopped because of that. So then you have to think, okay, well now I have to think of raincoats that people can wear that have the MSF logo on it so that you can see. But those things being very clearly identifiable is really important. I think it's important for the local community to know who these people are that are working for MSF. So especially in particularly tense environments when I have new staff coming, I try to introduce them to the local authorities, the Ministry of Health, and the local militia, so that they know this person is the supervisor of this outreach team, and they will be going every Tuesday to this and this village, and then there's a facial recognition as well, and they have the opportunity to build up some kind of a rapport and relationship.
Great.
I'd just like to add that we've seen some very interesting sort of ways to protect health workers locally through some of our colleagues, notably, for example, in the Democratic Republic of Congo, a very prominent surgeon, Dr. Denis Mukwege, who's been lauded around the world for his work treating survivors of sexual violence at Pansy Hospital. He was attacked by gunmen. His bodyguard was killed in front of his children, and he was left for dead, and he narrowly escaped this attack. And when he did leave the country for a while, but when he came back, basically his biggest protection, frankly, was his community. And the entire community came out and said, we are going to protect this doctor, we are going to protect our hospital. They escorted him everywhere. And one of the challenges is getting peacekeeping forces, because of course one of the largest, or the largest, I think, peacekeeping operation in the world, MONUSCO, is on the border, the eastern border of the Democratic Republic of the Congo, and for a long time they would not protect health facilities because they said their job was, you know, really to stop armed attacks in the conflict, and they didn't see civilian facilities as objects of their protection. And I think this is where we need to move to assure that those kinds of facilities that are really bulwarks of the community are also protected by peacekeepers. That's not the same as it's not compromising the unarmed health delivery but it is saying that, if they're attacked, then peacekeepers should be vigilant in watching it. I think the third thing is maybe there needs to be more international hotlines, so that, with communications the way it is today, we should be able to know what's happening and be able to respond outside of the country if they can't protect themselves inside.
Just to add to that, I think another best practice, and it seems very simple, but it's the process of, as you mentioned, is listening. And so it's not only listening to your community members, and in all cases listening to your staff. And time and time again, I've seen the failure in transparency. So if there is an issue, if there has been an incident, it's the ability to divulge into that incident more clearly and transparently amongst everyone in your staff, as well as to really clearly outline that every single person in the staff has the tools that they need to negotiate through circumstances they might face. Of course, you can't prepare for anything, but in so many times we're working so incredibly fast, and it's so much staff turnover. It's so easy to say that, oh, your security brief was postponed and you already started to work for 2 weeks, and yet that can't happen in so many circumstances.
I should have probably asked this question a little earlier in our discussion, but Susannah, you just mentioned the attack on Dr. Mukwege, and I was watching a video last night in preparation for today that showed a fairly severe bombing on hospitals in Aleppo and Syria. Can any of you, I guess, give us a little bit more of a background on why healthcare workers are targeted specifically? Because there's several different reasons why these attacks exist, and I think that was my fault for not maybe addressing that a little earlier.
Well, I think there are many reasons, and as Len said last week, the context is everything, and there are many different reasons. In Syria, healthcare and health workers have actually become a target. A strategy of war in Syria is to attack health. And numbers are almost numbing, but I just want to give our latest numbers because we, Physicians for Human Rights, has a map on our website, and the data that documents attacks on health in Syria. And every month those data are given to the UN, and they're reported in the Secretary General's report to the UN Security Council in Syria every month. And this week we've just issued our latest numbers. And total now, since the war began in Syria, there are at least 256 attacks on 194 separate health facilities in Syria, 90% of these by the government. And just in the last 4 months alone, we've documented 53 attacks in total, the largest number that we've seen since the war began, which means that it is not getting better, it's getting worse. And in terms of health professionals, at least 624 medical personnel have been killed in the line of duty, most of them, 97% of those by the government, and a third of them by shooting. 92 of those have died under torture, and 56 by execution. So you can see from these numbers, and they're really chilling, that in Syria at least, attacking the hospitals and health workers is a strategy of war. Why? Because these are the doctors who are treating the enemy. And who is the enemy? Civilians. The enemy is Homs, Aleppo, Idlib, all of the towns that are now controlled by the opposition. So it's horrific. There are many other reasons, and I think there's a case by case. We don't know why Dr. Mukwege was attacked in the Congo, but it's very possibly because he was speaking out about sexual violence in his country, and some people saw that as an attack on his country, or that he knew from his treating a particular person that person was a victim, and maybe that he might know who did it. In Sri Lanka, we saw doctors also being attacked during the end of the civil conflict there because those doctors were the first responders, and they were speaking out to the media about the killing and shelling of their doctors and hospitals. And so very often they are the people who are speaking for the victims, and the people who are doing this are going after them.
Thank you. Ladies, did you have things? We're getting some really wonderful questions from online, so thank you again for those of you who have tweeted so far. Please continue to send in your questions at Humanity and More using the hashtag Humanity and More. The next question, just to complicate things a bit further, is is that what happens when a disaster strike hits a conflict zone? So, for example, the tsunami in 2005. What changes, and are there any lessons that we can learn from that situation, how we can better implement protections or responses?
There's definitely been examples from history, recent history, where in conflict-ridden areas, where a natural disaster actually influences peacekeeping, and it actually influences the ability of first responders as well as the humanitarian community to actually enter. So there's also been some really nice work retrospectively on the crises in Nepal, Mozambique, and East Timor, where in post-conflict settings, the health indicators have actually been able to improve. So it's not to say that every single conflict is necessarily the absolute turning point towards bad, but they've pointed to specific factors, and one of the main ones has always been around a true coordination. Michelle and I were sharing a sort of cynical giggle about the word coordination and how sometimes the meaning is lost now because we throw it around so much, but true coordination between various partners to really work together is one of the main factors that influences the ability to actually move forward out of conflict, to respond to disaster, or just to move forward itself.
Great. We have another question. I think it might be interesting for all of you, asking about the advantages and disadvantages of working on these issues as either advocates and practitioners versus from within the government, and maybe how those roles can differ or work together, given that I think this is such a complex issue. And the two of you are medical practitioners, and Susannah, you work on policy issues, but there's very clearly a role for governments to play, not only the U.S. government, but other governments, ministries of health, and regional bodies, etc.
That's a hard one.
Yes, thank you, Jordan.
Thank you.
Do you want to go for it?
Well, I mean, there's certainly a huge role, and I mean,
At the end of the day, if governments and officials aren't dealing with this, it's not going to be fixed. So that's for sure. And I mean, when we talk about governments, we can talk about intergovernmental organizations like UN agencies that have responsibility to deal with this, and that includes the UN Human Rights Apparatus. There is a special rapporteur on the right to health. This is one of the briefs of that office, it should be, and it has been. And also, of course, the Security Council that should be dealing with the protection of health in conflict as a peace and security issue. And then, the UN General Assembly in terms of implementing this resolution, which means every government should be establishing procedures to protect health, both in conflict and non-conflict, so that we start there. But in terms of, some of these situations where they've created corridors for medicine to be delivered in the middle of a war, or for vaccinations especially, that involves a negotiation between, let's say, a military or a ministry and a Ministry of Health, and possibly armed opposition groups. In El Salvador, actually, towards the end of the Civil War, this is probably the strongest example that I know of in history, there were actually meetings to protect medical neutrality between the Ministry of Defense and the Ministry of Health of the government and the FMLN, the armed opposition. And it was to try to create agreements on protecting hospitals and protecting health workers. So I think there's a very important role for governments to uphold these norms. And we need to see more creative solutions.
Great. I did want to open it up then to the audience here in the room. We've had lots of questions online, but I wanted to give you all the opportunity to ask any. There's a microphone located here to my right. So if any of you have questions, I do have a few more from online audiences. So if you want to be thinking of what your question is going to be, then please join us up here at the mic. So the next question we have that was tweeted in was, how are healthcare personnel regarded in armed conflict when they joined one of the parties? Are they protected?
Well, I can say from an MSF perspective that goes back to our lovely list of best practices, is whenever our staff join MSF, that they go through a briefing of, you are now part of MSF, and you wear that MSF identity when you're at work, but also people in the community know that you work for MSF. So if you're actively involved with one side or the other of a conflict, that won't work. So you have to make a choice now that you're going to focus and be a healthcare worker. So that can be difficult. I have been in situations where I have been told by the local military group that my healthcare worker is working for the other side, like in the example I gave in Central African Republic. And that's really difficult. I mean, I can ask my staff member, okay, are you? But that actually doesn't really matter, because the point isn't whether they are or not. The point is that they're being accused of it, and they're going to do what they're going to do as a result of that. So I think that from our perspective, the biggest thing we can do is we tell our staff that you can't be also part of a military group if you're part of our staff, but as well that they need to be really careful about perception and how they're perceived. So having a conversation that could be overheard by someone else, where they're talking about certain political ideas and values, can be really dangerous for them. And it can be dangerous for any member of the community. So usually they know that better than I do, so they're even more careful than I would be. But yeah, that's kind of how we combat that.
Just to
Clarify, under international humanitarian law, and that's the point of the law, is that everyone is protected providing that they're adhering to their medical duties and they're not being actual party to a military operation. So health professionals who are in an armed opposition group, if they are providing health care to the sick and wounded impartially and without discrimination, they absolutely are and must be protected. That's the whole point of the law. And unfortunately, you see all too many cases where governments fail to understand this, whether in a human rights law situation in peacetime or in a war. For example, in Bahrain, where the doctors were arrested for treating the injured demonstrators who the government perceived as the enemy or opposition, and they weren't even armed opposition, the doctors were accused of being enemies of the state and treasonous and this and that, and they were arrested. That's absolutely a violation of the fundamental principles of medical neutrality. As soon as a health professional actually picks up arms and starts to fight with one party or another, then they lose that neutrality, including in our own military in the United States. I mean, if a soldier, a doctor drops his medical neutrality and his role to treat the sick and wounded and starts to fight, they can be a target.
I think it's also quite incumbent on any organization, once they're working in any kind of setting, is to have a thought process and some kind of protocol in place for dealing with what if one of your staff members does become active or is seen as a threat and is threatening the operations, and to think through that prior to that becoming an actual reality rather than when it does. Because if, in some cases, just one staff member can jeopardize your entire operation and integration within a community.
And I think that's the importance
Importance of the education that the International Committee of the Red Cross does, and the Red Cross and Red Crescent societies, is to distinguish these norms so that, indeed, international humanitarian organizations are not going to be part of an opposition group. They're there because they're neutral. But it's not required that health professionals be politically neutral in their own countries, just as we aren't here in our country.
Absolutely. All right, I'll open it up then to the floor. Yeah, please, of course. And if you can speak into the microphone, maybe tell us your name and your affiliation before asking a question.
Good afternoon, my name is Hugo Reñas. I come from Ecuador. So I'm studying an MBOLDen program at UW. I have been involved in international humanitarian affairs for a time with the Ecuadorian Red Cross. I have a question for the sort of organizations. How do you manage neutrality, impartiality, when you get involved in a judicial process? Are you being called to testify in the judicial process? How do you manage it? Thank you.
Or if you haven't, maybe if anyone in your organizations have faced it.
How do you manage it? It will happen. You are called to testify in the judicial process.
I mean, I can say as healthcare workers, we are often called to testify in courts, and as Doctors Without Borders, we do what we would do in the United States or anywhere, is that if we are asked to testify, for example, like in a rape case, in Congo is a great example of this, where there's been quite a lot of judicial processes in relation to mass rapes, and they've asked doctors to come and testify based on their findings. And this is, of course, we would do this like we would do anywhere and say, we can report as medical practitioners. Beyond that, it becomes a little bit complicated for us because we are doctors and nurses. We don't have necessarily an additional expertise that we can give. But I will say, there are times when we also will speak out and bear witness to testify against some of the things that we see, because we want to be able to speak for our patients who don't have that platform to speak for themselves. So it's not maybe as specific as you want it, but
I'll just add that I think
I think this is a very fraught and difficult issue, and many humanitarian organizations are, the international ones, when they're in a country where there are mass crimes, have been very nervous about that role, and rather see the human rights organizations do that job and let them do their medical care. But because they're very often on the front lines and they have documentation, it's very much desired. And there's still a lot of tension and discussion around what is the proper role of both local health professionals, which would be to provide documentation if the patient gives informed consent and wants the judicial process to go forward. But for the international humanitarian organizations that are there in a neutral capacity, they have a lot of challenge and have, many of them, established agreements with the International Criminal Court, for example, where they wouldn't be compelled to testify. But we hope that they will indeed collect forensic evidence and give it to the local survivors so that those people, as patients, can bring it to court. And I think that's what Doctors Without Borders, the International Rescue Committee, try to do.
I have been asked by local authorities, Congo again, to say, but I need you to tell me, was she raped? And it's like, dude, there's no rapid test that says positive, yes, she's been raped. What I can say is we can give the patient a medical report that says these are our findings. But there also are limitations of that judicial process sometimes where they ask the medical workers to do things that we actually can't do. What we can say is what our findings are medically, and that information does not belong to us. That information belongs to the patient, and it's up to them to decide what they reveal in a court of law or to local authorities.
One little further point, though, this is exactly where my organization comes in, because we are training doctors and nurses to gather forensic evidence, because that's our skill set. It's not what Doctors Without Borders or IRC, well, sometimes IRC are being trained to do this, but I believe that increasingly health professionals all over in these situations should have the skills or should be treating local partners in how to gather medical evidence of torture, rape, and so forth, and that's what we do. It might not be the job of emergency humanitarian aid workers per se, but we work in partnership with them so that we can do that and they can do their thing.
While all of you are still thinking of more questions and tweeting them online, I wanted to ask a follow-up question to you, Susannah. You had mentioned before that there need to be better tools for prosecution, and the training that your organization is providing and training local authorities on this issue is something that is fantastic. What kinds of tools would you like to see created or are currently being created to help in this process?
It's a whole sort of new and expanding area of protection of individuals who are victims of armed conflict, especially the mass atrocities that are occurring. Physicians for Human Rights has training programs now in Kenya and the DRC, and we're also doing it on the Syrian border, and in many other parts of the world, actually, with Storms on Torture, where we're providing sort of guidelines and training, deep training, on the forensic documentation of human rights violations that have physical and psychological consequences. So the tools are very basic. It's just how do you do a head-to-toe exam of a rape survivor? How do you document? How do you do a medical record of this? forensic photography. So increasingly cameras that are, now we have these tiny little cameras and they are cheap, and we can train people how to do forensic photography and include it in a criminal report. We're also developing a mobile app. It's called Medicapt, which is going to be used not only to allow doctors on an app very easily in remote areas to load up the medical record of let's say, a forensic rape exam or a torture exam into a cloud, so it will be securely held up there. But you can imagine once we gather data like this electronically with full informed consent and security, we can also track mass crimes, because we can track it across geographies, types of attacks, weapons used, kinds of perpetrators, patterns, etc., which will help us document mass crimes in a larger context among whole populations, not just an individual victim.
Great. Any other questions from the audience?
I'm Tom with International Medical. Good to see you. I have a question actually probably for two of the more operational organizations here about the financial systems. You asked a little bit about how financial systems can change, especially in protracted crises, to complement the kind of more relief to development topics that's discussed in natural disasters. How would you say recommend financial systems to change in regards to conflict situations? I think a lot of organizations struggle with grants that are 6 months to 8 months, and then we have a Syrian crisis that's been going on for years.
Well, in MSF we're very lucky. I always feel bad about answering questions about funding because we are predominantly funded by private donors, so we don't really have to deal with the whole grants circus and cycle that most other organizations have to deal with. In fact, I had to do it once in South Sudan, and I was so angry that I was like, I was afraid myself, I shouldn't have to be doing grant stuff. But it does happen from time to time, so but predominantly we are funded privately. And that really gives us a lot of flexibility. I mean, so yeah, then we can really respond to the needs and we dictate it. It's not ECHO, it's not USAID, it's not one of these other massive funding mechanisms, which may, you know, they're going to have their own reasons for releasing funds for certain things, whereas we can say on the ground, these are the needs, these are the priorities, and we can fund it directly, and we don't have to wait for the grant approval process either. So, I mean, that's our way, but I know that's not true for all organizations, so we're a bit lucky in that.
It's a terrific question, and I think it's very timely given that 2016 is the World Humanitarian Summit, and we are on the eve of humanitarian reform, and as we all know, the Core Humanitarian Standards and Core Humanitarian 3 is about local networks, and I fundamentally believe in, this is what my current organization is working towards, is local response network strengthening. And one of the very timely topics is around how do we bridge the current gap that humanitarian funding sits here and local networks and local response sit here. And while we now recognize more and more that it's much more of a continuum, there's actually a cycle, and it's not just relief/development at this 2-week or 2-month or 2-year point. Strengthening the local networks as the first responders and ongoing responders is the way forward. And so, while I don't have the answer, I am relatively cautiously optimistic that we are moving in that direction, and bringing in local networks and bringing them that funding will be that very, very necessary gap fill.
And I forgot to mention earlier that Neena is the executive director of an organization called emBOLDen that is doing really fantastic work on this. And I know at the Emerging Humanitarian Frontiers conference that we hosted a couple of months ago, we had a lot of discussions about how can we empower local communities, how can we better listen to local communities, identify needs, and do a better job of bringing information from the bottom up rather than just having these top-down priorities handed to local communities who might say, well, this absolutely makes no sense for us, this is not what we need, and we need these things over here, and you're giving us other things over here. I think one other point that I wanted to make that struck me in a way was that many communities are saying, we don't want stuff. We don't want humanitarian organizations to just come come in and bring us things and ship us things. We want to be trained, we want to be given skills, we want to be given opportunities, we want to be able to have jobs in order to provide for our families. So creating that community resilience is the thing that they want most. And I think one of the biggest issues for the humanitarian community is that we think, oh, disaster or conflict, we just need to ship tarps and blankets and food, and then that'll solve the problem. And that's oftentimes not what they want. So it's definitely a very complex issue for sure. Any other questions from the room? We don't bite across. Any other questions from online? Oh, we do. And just remember, for those of you who are watching online, you can tweet your questions at Humanity and More with the hashtag Humanity and More.
Good afternoon, everyone. My name is Diego Beltran. I'm from Ecuador. I'm National Security here in GW. And I'm first very glad to see that it's an all-female panel in a very, very traditionally conceived field for male leaders. So I'm congratulate the panel organization. And I don't know if it's a coincidence or it's purposeful, but the question is actually addressed to that, and I want to know, in your view, in your opinion, if I'm lucky, all of you will jump in on this. What are the additional challenges and the additional threats that women face, women healthcare providers face in armed conflict? I mean, we all know that female population are traditionally more exposed to specific forms of violence. What are these challenges like for female healthcare providers? Do they face any additional challenges, or is it the same? I would like to know that, especially when considering some of these fields of operation also have a lot of cultural barriers that women face, where male will consider their female counterparts inferior or second-grade citizens, if you will. English is correct in that question, but please feel free to explain that. Thank you.
Great question. And to answer your first question, this was not on purpose. We do have a commitment to know all male panels, but it was not actually on purpose that it was all female panel. I just got the most qualified people I could possibly find.
I can say a couple things, and I'm sure you have a lot of examples from the ground. But of course, sexual violence is one, and not that men are not also victims of sexual violence, because that can also happen. And in fact, we have male colleagues who have been sexually violated as well in the line of duty. But I think the hierarchy is a big thing. We see in our trainings, where we're training both doctors and nurses, that there is this hierarchy of power. Most of the people, first of all, in many countries where we're working, most of the doctors are men and most of the nurses are women, much as it's been in most of the world. And there's a very strong hierarchy and distinction between the two in terms of status and everything else, financial. That's one. Second, a very interesting one is, I think, because of cultural differences, mobility. So in Congo, for example, it's very difficult for women lawyers, women police, and women health professionals to move about. They don't have access to transport, they often aren't driving, they often don't have a car, and very often their spouses won't let them travel. So that's very limiting in terms of just sheer mobility. So I think there's vulnerability, and there's a lower status, and there's sort of discrimination.
In both Congo and in South Sudan, and in two projects I worked in there, this was a big discussion with some of our female staff, because not only is it harder for them sometimes to have access to the education and training programs so that they can become healthcare workers, but they also have families to take care of, and they're breastfeeding their kids, and they live far away, and they're in a conflict area, so walking home long distances in the early morning or later at night after their shifts can be really difficult for them. So in both of those projects, we designed our shift hours around that, so that, and you know, allow them, family member would bring the baby so they could breastfeed the baby. We had the shift hours, like the night shift was longer so that they were coming to the hospital in daylight hours and then leaving the hospital during daylight hours. So there are things that we can do creatively to ensure that our female staff members are protected, but it's also about training. And being a female myself, I'm often teased by my staff that I always hire female staff, which is not necessarily always on purpose, like this panel, but it can happen that way. And I think it's also really something cool for me as a female manager myself and coordinator, that people see that and they like that, and it sets an example of female leadership and female empowerment, and that's also really important. So that's something that I think we can also do as international organizations. We don't always do it. I think most international organizations, MSF included, a lot of the higher leadership is often predominantly male, and I think we also need to lead by example. If we want to set an example and tell these communities to empower their women, we also have to do that ourselves. So yeah, it goes all ways.
Just to add to that just a little bit on everything has been so well said. One is, it's always critical to keep in mind, as we've talked about earlier in this panel, that the vulnerabilities and the risks are not experienced the same across all segments of our populations. And so to keep that in the forefront in our heads. That being said, sometimes your female staff can actually have access to those vulnerable subsegments that other staff may not. And so to how to actually work that to an advantage in some cases. And then the second thing just to add is, in some situations where it's more culturally appropriate to have a man leading your team, I have no problems taking a male colleague to a health-directed meeting, even though they're not a health practitioner, and having them lead the meeting and I sit in the back. And that's just part of how to get things done.
Great. We do have another question online. What role can healthcare play in rebuilding and stabilizing after conflict?
Well, I think when communities are healthy and have access to healthcare, that is a huge stabilizing factor. I mean, we see, when communities are sick and dying and they have no access to any kind of healthcare, that is a very destabilizing factor. So yeah, for sure that bringing in healthcare, I think just by its very nature will help to stabilize things a bit. As MSF, we don't really do like post-conflict reconstruction work or anything like this because we are a healthcare organization only. But yeah, I think just by its very nature, it can have a stabilizing effect.
In so many settings, we in healthcare for quite some time have been tired of the siloed approach. And so we often talk about the knock-on effects that HIV/AIDS has a lot of knock-on effects of strengthening other programs, same with polio in post-conflict or conflict-affected countries, that the actual infrastructure being developed to reach the most remote areas and the supply chain and cold chain around that will be left in place to actually help direct that in the future. And same with, hopefully, with a lot of the response to Ebola in Sierra Leone, Guinea, and Liberia, that in those post-conflict settings where Ebola has really been devastating, but the response is actually left in place to then further strengthen, although it will take definitely much more time and many more resources.
And just from a human rights,
health and human rights perspective, there's all the devastation that has been caused by violations during the conflict. If they're swept under the rug and there isn't a process for truth and reconciliation or for accountability, we believe that these kinds of crimes and these kinds of conflicts will just persist. And so there's also very often the issues that we're dealing with post-conflict have to do with identifying human remains, reburying the bodies of those who have been killed, helping families retrieve their loved ones, helping the whole society acknowledge what has happened. And then there's this enormous sort of overlooked area of trauma, the psychological trauma. We see in Syria now several generations of completely traumatized young people who also have been denied education. And you're going to see, in DRC as well, you have the problem of the demobilization and rehabilitation of child soldiers. These are kids who are now in their 20s and early 30s who have basically not been socialized at all and have done nothing but rape and pillage and kill. And they've had guns in their hands since they were 9, 10, 11 years old. So the health response to that, it poses enormous challenges. And the most important thing, we've all said this in our various ways, is empowering communities to be involved in the rebuilding process from the ground up, including the rebuilding of their own health systems. And the systems approach is essential. And what we've seen in Liberia and in so many post-conflict areas, I mean, where we have not invested in personnel, we've not invested in training and giving capacity to health professionals and jobs, we don't see a system that can cope with the next epidemic or health crisis. And we need to invest in it, and it's long, slow, hard, unglamorous work, and it's very hard to get the funding for that, but it's absolutely essential.
Right. And as we talked about with Len last week, one of the reasons why the Ebola epidemic spread so widely and so quickly in Sierra Leone and Liberia was because those are post-conflict situated countries where the infrastructure hadn't been built up enough to be able to address the outbreak. I'll maybe take one more question from the audience if there are any here.
Coming up. I'm Grace Armstrong. I work for a humanitarian consulting firm called Protect the People. And I know we talked about a little bit in the beginning, the General Assembly resolution to protect healthcare workers. I wanted to know how the UN and other international organizations or transnational organizations can help support the implementation of that resolution.
I think,
one thing is to sort of join coalitions that are working on that, including the Safeguarding Health and Conflict Coalition, and also to, for all of us to ask our own governments, how are we going to implement that resolution? So there actually there's a Medical Neutrality Act that's going through Congress as well, but every country needs to address it itself, and so that's one way. And second is to participate in the ongoing documentation of these kinds of violations, because as we know, we don't have a systematic way to collect data. And if we don't know the problem, and we don't see the problem, and we don't define and describe the problem, we can't really address it. So that, I think, is the most important thing, and I think that educational forums like this are the first way to start working on the implementation. So I want to thank the American Red Cross for hosting this, and Humanity and More, because I think this is one of the most important ways to get started.
And that's actually a great segue to my last question for all three of you, really, is we've talked about different ways that the international system, international humanitarian organizations can all do a better job of supporting this issue. But for those of us who are here in the room or watching online, what can we do as individuals to support these efforts or to learn more about these issues, because they are very complex and very rich?
So we're the advocacy
organization here. And I just want to say, I admire enormously the work of the operational colleagues here in the humanitarian community, and very often their hands are tied in terms of speaking out all the time. Some organizations are more robust than others in speaking out, but others many are in very difficult situations. So I see the job of groups like Physicians for Human Rights to get that information and interact with the humanitarian community and then help to speak out. So I urge you to follow us. You'll see a lot of information on our website. It's phr.org, very easy. And also track, that what the UN is doing and the World Health Organization on this. There's also the International Committee of the Red Cross Healthcare in Danger campaign. It tracks with this, and as we've mentioned several times, the Safeguarding Health and Conflict Coalition. These are three sources, I think, of good information and advocacy opportunities. In terms of Syria, which is very much on my mind every day, and the crisis is so horrific, we have an amazing U.S. And Syrian partner, the Syrian American Medical Society, SAMS. They have an incredible website and presence online and on Twitter where they're constantly feeding information about how they basically have created a parallel health system with other Syrian colleagues, and incredible response and courage, their training on all of these issues, and we should be supporting them as well.
I think it's really helpful to stay informed, and for those who do a lot of analysis on policy, whether it be it from a humanitarian perspective or looking at foreign policy and conflicts, is to really see the whole picture. And we're asked to work in war zones, in which we do, but that means we work in a war zone, and that means that the dangers that the community and the population is put in is also faced by healthcare workers and by humanitarian workers. So it's important. I think that's the place to start, is just to understand really that kind of holistic perspective of what we're faced with.
I don't have much to add to what's been said that's been so proactive. I think definitely an understanding of the vulnerabilities and risks and how they're not weighed equally amongst all of the segments of our staff, of the populations, of the communities is quite important, and that along with that we also not just transfer the risk and the vulnerability, but the ability to manage that and the resources and the funding to really manage that and rebuild infrastructure over the long term, and to understand the generational impact. And from the moment that we intervene, to always be thinking of that longer term and push toward the longer term funding for our local partners and for their engagement to build back their own communities better and to help them do so.
Yeah. Great. And I did, again, just want to reiterate some of those websites, phr.org. You can also check out the Safeguarding Health and Conflict Coalition website. They've got a lot of really concrete steps that you can take to either learn more or to become involved in this area. And of course, the ICRC Healthcare in Danger platform online has a lot of really wonderful suggestions and best practices for how organizations can do a better job of providing these protections, and also how individuals can be involved. So I wanted to give a huge thank you to our panelists. This has been a really fascinating discussion, and I've learned so much. I hope all of you have gotten inspired as much as I have by this conversation, and I appreciate you all joining us today. So thank you.